So far we are done with the bony features of typical and atypical ribs. We are done with the differences between typical and atypical ribs. Now we'll do the attachments of 12th rib, ossification and clinicals of ribs. This is an image of 12th rib of the left side. This image is showing the inner surface of the 12th rib, attachments on the inner surface of the 12th rib. This is posterior end of the rib, this is shaft, and this is anterior end. As I told you in my previous lecture, that 12th rib, it only consists of a head and an anterior end. It does not have any neck and tubercle. This is the shaft of the rib. The head of the 12th rib, like all other typical ribs, it provides attachment to the capsular and radiate ligaments of the costovertebral joint. Coming to the attachments on the inner surface, the first muscle which is attached on the inner surface is the quadratus lumborum muscle. This one is indicating the insertion of the quadratus lumborum muscle on the lower part of medial half to 2/3 of this surface. The fascia covering the quadratus lumborum is also attached to this part of the rib. This is the fascia covering the quadratus lumborum, which is also known as thoracolumbar fascia. This thoracolumbar fascia, it is a tough membrane which is composed of 3 layers: anterior, middle and posterior layer. This thoracolumbar fascia, it covers the deep muscles of the back. These deep muscles of the back are also enclosed in this fascia. As you can see here, the quadratus lumborum, which is enclosed in this deep fascia. Then there is insertion of the internal intercostal muscle near the upper border. This one. The costodiaphragmatic recess of the pleura, which is basically a potential space in the pleura. We'll talk about the pleura and costodiaphragmatic recess in our subsequent lectures. For now, just remember its name and level. This recess is related to the medial 3/4 of this costal surface. This line is indicating the level or relation of costodiaphragmatic recess of pleura to this surface. The last muscle which is attached to this surface is diaphragm, which takes origin from the anterior end of this surface. Now coming to the attachments on the outer surface of the 12th rib. This is an image of the outer surface of 12th rib. We'll start with the attachments of medial half of this surface. Medial half of this surface, it provides attachment to the costotransverse ligament along the upper border of this surface, lumbocostal ligament along the lower part of this surface and along the lower border of the 12th rib, and the lowest levator costae muscle along its upper border. Then comes the attachments on the lateral half of this surface. There is insertion of serratus posterior inferior to the lateral half of this surface. Then we have origin of the latissimus dorsi muscle along the upper part of the lateral half of inner surface, and origin of external oblique muscle along the lower part of this surface. Intercostal muscles are attached to the upper border of this rib. As I have told you, in the attachments of a typical rib. The lumbocostal ligament is attached to the lower border of the 12th rib. Middle layer of thoracolumbar fascia is also attached to the lower border, and lateral arcuate ligament is also attached to the lower border, just lateral to the origin of quadratus lumborum muscle. That's all about the attachments of 12th rib. Now let's talk about the ossification of ribs. A typical rib ossifies from one primary center and three secondary centers. This is an image showing a typical rib. One primary center for the shaft appears just near the angle at this point at about 8th week of intrauterine life. Three secondary centers, one for the head and two for the tubercle. This is the tubercle. One secondary center appears for the head and two for the tubercle at puberty, and they unite with the rest of the bone after 20 years. Now let's talk about the ossification of first rib. Ossification of first rib is almost similar to that of a typical rib. The only difference is that it ossifies from one primary center and two secondary centers. Primary center for the shaft and two secondary centers, one for the head and one for the tubercle. Otherwise, its ossification is similar to that of a typical rib. Now, the ossification of 11th and 12th rib. 11th and 12th ribs, they ossify from one primary center for the shaft, as we talked about in case of a typical rib, and they have one secondary center for the head. As you already know, the 11th and 12th rib, they don't have neck and tubercle, they only have head and anterior end. So they ossify from one primary center for the shaft and one secondary center for the head. That's all about the ossification of ribs. Now we'll talk about the costal cartilages. What are costal cartilages? Costal cartilages represent the unossified anterior part of ribs. This blue colored portion, which is attached on the anterior end of the rib, this is the costal cartilage. Costal cartilage is made up of hyaline cartilage. They prolong the ribs anteriorly and contribute to the elasticity of the thoracic wall, providing a flexible attachment for their anterior ends. These costal cartilages, they increase in length through the first 7 ribs. As you can notice, the size increase in size up to the 7th costal cartilage. The size then decrease gradually as we move downwards up to the 12th costal cartilage. The medial ends of the costal cartilages of first 7 ribs, they are directly attached to the sternum. As you can see here, the first 7 costal cartilages, they attach the ribs directly to the sternum. That is why the first 7 ribs are known as the true ribs. While the costal cartilage of the 8th, 9th and 10th rib, which is 8th, 9th and 10th rib, as you can see in this image, they are not directly attached to the sternum. Instead, they articulate with one another and form the costal margin. This area, which you can see in this image, is the costal margin. What is the costal margin? The 8th, 9th and 10th costal cartilages, they articulate with one another and form the costal cartilage, costal margin. The 11th and 12th ribs are small. Their cartilages are free. The 11th and 12th cartilage, they are not attached to any rib or cartilage, any bone or cartilage, they are free. Now talking about the direction of the costal cartilages, the direction of costal cartilages is variable. As the first costal cartilage approaches the sternum, it descends a little, as you can see here. The second costal cartilage is horizontal. The third costal cartilage, it ascends slightly, as you can notice here. The remaining costal cartilages are angular. They continue the downward course of the rib for some distance, as you can see in this costal cartilage, and then turn upwards to reach either the sternum or the next higher costal cartilage. The lower costal cartilages, they have the angular direction. Now let's talk about the parts and attachments of the costal cartilages. Each costal cartilage has two surfaces, anterior and posterior, two borders, superior and inferior, and two ends, medial end which is attached to the sternum and lateral end which articulates with the anterior end of ribs. Talking about attachments on the anterior surface of costal cartilage, the first costal cartilage, it articulates with the clavicle and takes part in forming the sternoclavicular joint. This is clavicle, this is first costal cartilage. It forms a part of sternoclavicular joint, so it gives attachment to the sternoclavicular articular disc, the joint capsule of sternoclavicular joint, the sternoclavicular ligament, and the subclavius muscle. The second to sixth costal cartilages, this is the second costal cartilage, third, fourth, fifth and sixth. As you can see in this image, the second to sixth costal cartilages, they give origin to the pectoralis major muscle. The remaining cartilages, they give attachment to the flat muscles of anterior abdominal wall. 8th, 9th and 10th costal cartilage, it gives attachment to the internal oblique muscle of abdomen, while rectus abdominis muscle is attached to the 5th, 6th and 7th costal cartilage. Now talking about the attachments on the posterior surfaces of costal cartilages. The first costal cartilage, posterior surface of first costal cartilage, it gives origin to the sternothyroid muscle. This one is the sternothyroid muscle. The posterior surface of second to sixth costal cartilages, they receive insertion of the sternocostalis muscle. This is the sternocostalis muscle. While 7th to 12th costal cartilages, they give attachment to the transversus abdominis muscle and to the diaphragm. Talking about the attachments of the two ends, medial end and the lateral end of costal cartilages. The lateral end of each cartilage forms a primary cartilaginous joint with the rib, concerned rib. The medial end of the first costal cartilage, it forms a primary cartilaginous joint with the manubrium. The second to seventh cartilages, they form synovial joints with the sternum. The 8th, 9th, 10th cartilage are connected to the next higher cartilage by synovial joints. 8th, 9th and 10th, they are connected to the higher costal cartilage through synovial joints. The ends of 11th and 12th cartilages are pointed and free. This is the 11th rib, this is the 12th rib. Their cartilages are free and pointed. Now the superior and inferior borders of the costal cartilages, they give attachment to the intercostal muscles and the external intercostal membranes of the intercostal spaces. The intercostal space is the space between the two ribs, So the superior and inferior border of costal cartilages, they give attachment to the intercostal muscles and external intercostal membrane of the spaces. The 7th to 10th cartilages, they articulate with one another at the points of their maximum convexity to form the synovial joints at this point. Now the next topic for discussion is intercostal spaces. Intercostal spaces, as their name suggests, inter means between and costal means bones. So intercostal spaces are the spaces between the two ribs. As you can see, this space between the two ribs is the intercostal space. Intercostal spaces separate the ribs and their costal cartilages from one another. The spaces are named according to the rib forming the superior border of the space. For example, the 4th intercostal space lies between the 4th and 5th rib. The spaces are named according to the rib which is forming the superior border. So the space between the 4th and 5th rib will be known as 4th intercostal space. As we have 12 ribs on each side of the midline, so we have 11 intercostal spaces. The space below the 12th rib is termed as subcostal space. It is not known as intercostal space because it does not lie between the two ribs. It lies just below the 12th rib, so it is known as subcostal space. And the nerve which runs in the subcostal space, which is the T12 spinal nerve, is known as subcostal nerve. The intercostal spaces are widest anterolaterally. The spaces widen further with inspiration and on the contralateral extension or lateral flexion of the thoracic vertebral column. The contents of intercostal spaces include intercostal muscles which are attached to the inferior border of one rib and superior border of the other rib, lower rib. They also contains the intercostal blood vessels and the intercostal nerves. Intercostal nerves are named on the basis of the space in which the nerve runs. For example, if a nerve runs through the 4th intercostal space, it will be termed as 4th intercostal nerve. This is an image showing the contents of intercostal spaces. This is the external intercostal muscle, this is internal intercostal muscle, and this one is the innermost intercostal muscle. These are the intercostal vessels and nerves which passes through the costal groove. The costal groove is a groove which lies on the lower part of inner surface of the ribs. That's all about the intercostal spaces. Now the clinicals of the ribs include rib fractures, supernumerary ribs, which are also known as extra ribs or cervical rib. The third one is rib excision, thoracotomy, and the last one is thoracostomy. Let's talk about these clinicals individually. The first clinical is the rib fractures. Fractures of the ribs are very common among chest injuries. We have to discuss the 5 points about the rib fractures. The first one is the common age group in which the ribs are very commonly fractured. In children, the ribs are highly elastic and fractures in this age group are therefore rare. With the increasing age, rib cage becomes more rigid due to the deposition of calcium in the costal cartilages and the ribs become brittle. So, the ribs rib fractures are more common in the old age than in the young children. The most weakest part is the angle. Common site of rib fracture is the angle of the rib, because the rib shaft is twisted at the angle and it becomes the weakest part for the fracture. Now, what are the symptoms with which a patient with a fractured rib presents to you? Severe localized pain is usually the most important symptom of a fractured rib. Rib fractures are very painful because the broken parts move during respiration, coughing, laughing, and sneezing. The periosteum of each rib is innervated by the intercostal nerves above and below the rib. So, to encourage the patient to breathe adequately or to relieve the pain, it may be necessary to perform an intercostal nerve block. The ribs prone to fracture are those that are exposed or relatively fixed. Rib number 5th to 10th are the most commonly fractured ribs. The first 4 ribs are protected by the clavicle and pectoral muscles anteriorly and by the scapula and its associated muscles posteriorly. 11th and 12th ribs float and move with the force of impact, but they are least common among the fractured ribs. The most commonly fractured ribs are from 5th to 10th rib. Although the first rib is protected and is not commonly fractured, but if the first rib is broken, it is associated with some complications, as I have told you in the relations of superior aspect of the first rib. The brachial plexus of nerves and subclavian vessels, they pass along the superior surface of the rib. So, these structures may get injured in the fracture of the first ribs. In addition to that, if the middle ribs are fractured, they may lead to associated injuries to the thoracic viscera, which may be lung, heart, spleen, etc. For this reason, rib fractures have been surgically plated and repaired. Now, the second important clinical is the supernumerary ribs, which are also known as extra ribs, cervical or lumbar ribs. Usually we have 12 ribs on each side, as I have already told you, but this number may be increased by the presence of cervical or lumbar ribs, or the number may be decreased by failure of the 12th rib to form. Cervical ribs are relatively common. What is a cervical rib? It is basically a congenital overdevelopment of the transverse or horizontal processes of the 7th cervical vertebra. This is 7th cervical vertebra. This is first thoracic vertebra. This is the cervical rib, which is basically the overdevelopment of the transverse process of 7th cervical vertebra. This rib basically arises from the anterior tubercle of the transverse process of 7th cervical vertebra. It may have a free anterior end, or it may be connected to the first rib by a fibrous band. This is the fibrous band through which this cervical rib is connected to the first rib. The importance of a cervical rib is that it can cause pressure on the lower trunk of brachial plexus in some patients, as the lower trunk of brachial plexus and the subclavian vessels, they are related to the first rib. So, the presence of a cervical rib may cause pressure on these structures and it may lead to the thoracic outlet syndrome. Patient may present with pain along the medial side of the forearm and hand and wasting of the small muscles of the hand. It can also exert pressure on the overlying subclavian artery and interfere with the circulation of the upper limb. This pressure may be released with the resection of the cervical rib. This resection is performed through a transaxillary approach, which means the incision in the axillary fossa or armpit. Lumbar ribs are less common as compared to the cervical ribs. Supernumerary ribs also have clinical significance in that they may be confused or they may confuse the identification of vertebral levels in the radiographs and other diagnostic images. Now, what is rib excision? Rib excision is commonly performed by thoracic surgeons to gain entrance into the thoracic cavity. A longitudinal incision is made through the periosteum on the outer surface of the rib, and a segment of the rib is removed. A second longitudinal incision is then made through the bed of the rib, which is the inner covering of the periosteum. This rib excision is required in cases of thoracotomy to gain entrance into the thoracic cavity. If the procedures on the lung or heart are performed, we need better exposure of the thoracic cavity. In these cases, the rib excision is performed by the thoracic surgeons. After the operation, the rib regenerates from the osteogenetic layer of the periosteum. The fourth clinical regarding the ribs is the thoracotomy. What is thoracotomy? It is surgical creation of an opening through the thoracic wall to enter a pleural cavity. Thoracotomy is of two types depending on the site of incision. It may be anterior thoracotomy or posterior thoracotomy. Let's talk about these individually. In anterior thoracotomy, surgeon makes H-shaped cuts through the perichondrium of one or more costal cartilages, and then there is shelling out of segments of costal cartilages to gain entrance to the thoracic cavity. After preparing the skin in the usual way, the physician makes an incision over the fourth or fifth intercostal space, extending from the lateral margin of the sternum up to the anterior axillary line. As I have told you in my previous lecture that we count the ribs at the level of sternal angle. Sternal angle is an important landmark for counting of the ribs. At this level, we know there is attachment of the second rib. So, just below the second rib, there is second intercostal space. In this way, we can count the intercostal spaces. This is second intercostal space just below the sternal angle. This is third, fourth and fifth intercostal space. The preferable site for thoracotomy is the fourth and fifth intercostal space from the lateral margin of the sternum up to the mid axillary line. This is mid axillary line, this is mid clavicular line. We can give an incision from the lateral margin of sternum up to the mid axillary line, any point along this line. The structures which are incised in case of anterior thoracotomy are skin, subcutaneous tissue, serratus anterior and pectoral muscles, external intercostal muscle, internal intercostal muscle, innermost intercostal muscle, endothoracic fascia and the parietal pleura. These are the structures which are incised during an anterior thoracotomy, and surgeons can expose the thoracic cavity to perform the surgery. Avoid the internal thoracic artery which runs vertically downward behind the costal cartilages about a finger breadth lateral to the margin of the sternum, and the intercostal vessels and nerve which extend forward in the subcostal groove in the upper part of intercostal space. Now, in posterior thoracotomy, the most common or preferable site is the posterolateral aspects of the 5th to 7th intercostal spaces. In general, a lateral approach is most satisfactory for entry through the thoracic cage. With the patient lying on the contralateral side, the upper limb is fully abducted, placing the forearm beside the patient's head. This elevates and laterally rotates the inferior angle of scapula, allowing access as high as the 4th intercostal space. Here is an image showing the incision line in case of the posterior thoracotomy. Here is another image showing the procedure of posterior thoracotomy. We ask the patient to lie on the contralateral side and the arm is fully abducted. Most commonly, rib retraction allows procedures to be performed through a single intercostal space following rib retraction. If wider exposure is required, surgeons use an H-shaped incision to incise the superficial aspect of the periosteum that ensheaths the rib, strip the periosteum from the rib and then excise a wide segment of the rib to gain better access to perform procedures in the thoracic cavity. This wider exposure is usually required in a procedure known as pneumectomy. Pneumectomy is removal of a lung. After the surgery, the missing pieces of ribs they regenerate from the intact periosteum. Thoracotomy may be used in cases of procedures performed on lung or the heart. Now, the last clinical is the thoracostomy. A thoracostomy is a small incision of the chest wall with maintenance of the opening for drainage. This procedure is most commonly used for the treatment of a pneumothorax. Pneumothorax means air in the pleural cavity, or it may be used to drain fluid away from the pleural cavity to allow the lung to re-expand. It may also be necessary to withdraw a sample of pleural fluid for microbiological examination. Thoracostomy may be of two types: tube thoracostomy or needle thoracostomy. Let's talk about these types individually. In tube thoracostomy, a tube is inserted into the pleural cavity to drain the blood, pus, or to withdraw the samples of pleural fluid for the microbiological examination. The preferred insertion site for a tube thoracostomy is the 4th or 5th intercostal space at the anterior axillary line. This is showing the site for insertion of a tube in case of tube thoracostomy. The tube is introduced through a small incision. The neurovascular bundle changes its relationship to the ribs as it passes forward in the intercostal space. As we know, the neurovascular bundle, it runs in the costal groove and in the intercostal space. In the most posterior part of the space, the bundle lies in the middle of the intercostal space. As the bundle passes forward to the rib angle, it becomes closely related to the lower border of the rib above and maintains that position as it courses forward. So, in insertion of tube in tube thoracostomy, we must keep in mind the course of neurovascular bundle through the intercostal spaces. We must avoid injury to these neurovascular bundle. The introduction of a thoracostomy tube or needle through the lower intercostal spaces is possible provided that the presence of the domes of diaphragm is remembered as they curve upward into the rib cage as far as the 5th rib. Avoid damaging the diaphragm and entering the peritoneal cavity and injuring the liver, spleen or stomach. These are all the precautions which we have to follow in cases of tube thoracostomy. The structures which are pierced in cases of tube thoracostomy, as you can see in this image, are the skin, superficial fascia, serratus anterior muscle, external, internal and innermost intercostal muscles. Then comes the parietal pleura and the pleural cavity. Here is another image which shows the insertion of a chest tube into the pleural cavity, and in this way the fluid is drained into the drainage container. In needle thoracostomy, a needle is inserted into the pleural cavity. Needle thoracostomy has an anterior approach and a lateral approach. In the anterior approach, the patient is asked to lie in the supine position. The sternal angle is identified, and then the second costal cartilage and second rib and the second intercostal space are found in the mid-clavicular line. So the preferable site in the anterior approach is second intercostal space in mid-clavicular line. In the lateral approach, the patient is asked to lie on the lateral side. The second intercostal space is identified as above, but the anterior axillary line is used. In the lateral approach, we give incision in the anterior axillary line, while in anterior approach, we give incision in the second intercostal space in mid-clavicular line. The skin is prepared in the usual way. Local anesthetic is introduced along the course of the needle above the upper border of the third rib. Then the thoracostomy needle will pierce the following structures, as you can see in this image. The first structure which is pierced is the skin, superficial fascia. In the anterior approach, the pectoral muscles are penetrated, while in the lateral approach, pectoral muscles are not present in the lateral side of the thoracic wall, as you already know. So the structures will be skin, superficial fascia, serratus anterior muscle, external intercostal muscle, internal intercostal muscle, innermost intercostal muscle, endothoracic fascia and the parietal pleura. These are the structures which are pierced in the needle thoracostomy. The needle should be kept close to the upper border of the third rib to avoid injury to the intercostal vessels and nerve in the subcostal groove. That's all about the clinicals of the ribs.